The lower extremity. The foot. This is a key region for postural function and the mechanism of gait. Hence, we begin by examining the foot as a whole. We begin with inspection standing. Looking from behind, we assess the shape of the heel and of the Achilles tendon, its width, whether it is straight or whether there is valgosity, whether the feet stand symmetrically, and how high the arch of each foot is. To assess this, it is useful to place a finger under the arch. We note whether the navicular protrudes, which is an important sign of foot pronation. It is less common to find a very high arch and foot supination, which is more characteristic for inherited deformity. If the arch is not equally high on both feet, there can be pelvic obliquity. In such cases, the patient puts his weight on the outer margin of his feet as a test. If the cause of pelvic obliquity is an asymmetrical arch, then this maneuver will correct the obliquity. The transverse arch is best assessed from in front. If it is flat, it may be concave when seen from above, and is frequently combined with a hallux valgus. This essentially static approach is not sufficient, however. To diagnose dysfunction, it is essential to examine the foot as it functions. Walking. Under normal conditions, the foot strikes the ground with the center of the heel and then moves forward on its outer margin, followed by pronation, when weight is transferred to the head of the first metatarsal, and finally, by toeing off, the heel moves off the ground. In dysfunctional flat feet, the foot sags under the patient's weight into pronation immediately after the heel strikes, owing to weakness of the muscles supporting the arch. In transverse flat feet, Vélez's test is positive. If our point of gravity moves forward without our lifting heels from the ground, reflex toe flexion occurs as we bend forward to prevent us from falling. In very frequent cases of dysfunction of the short toe flexors, this reaction is absent. The cause of hallux valgus is weakness of the short abductor of the first toe and unsuitable shoes. If we know these basic rules of foot function and dysfunction, rehabilitation therapy can be both rational and effective. Screening rotary test of the foot. The patient is supine, his leg bent at the hip and knee, supported by the heel. With our thumb and forefinger, we grasp the lateral end of the foot with the little toe and the medial end with the big toe and rotate it with very little force around the long axis of the foot going through the talus. There is no resistance until the full range of axial movement is reached under normal conditions. If, however, there is any disturbed function, most frequently in Lisfranc's articulation, there is movement restriction and resistance is met far sooner when we insist on rotation round the axis of the foot. If, however, we try to increase rotation, the foot deviates from its axis. Here in our patient, we can see blockage on the right side. At first, rotation takes place around the axis of the foot, but soon deviation from this axis can be observed. On the contrary, on the left side, rotation takes place around the correct axis until the full range of movement. The examination, however, does not assess function of the toes. The interphalangeal joints. We proceed in a similar way as for the hands. We fix the proximal phalanx between the thumb and forefinger of one hand, which must be supported, and mobilize with the thumb and forefinger of the other hand. Transitory movement in a dorsoplantar and lateral-lateral direction are carried out under simultaneous traction. Our fingers should be perpendicular to the direction of mobilization. The metatarsophalangeal joint. The same principles apply to the metatarsophalangeal joints as to the interphalangeal joints. With the forefoot fixed, we first distract the joint. Then we apply transitory movement in a dorsoplantar direction. Mobilization in a lateral-lateral direction follows. Not only transitory, but also rotatory mobilization with simultaneous distraction is possible. The most important technique is distraction in a plantar direction. We grasp the proximal phalanx to be treated between the thumb and the flexed forefinger, which serves as a fulcrum on the plantar aspect of the metatarsophalangeal joint. After engaging the barrier, a thrust is very effective. This technique can serve as first aid after distortion caused by stubbing and also for self-treatment. Lisfranc's tarso-metatarsal articulation. This is the articulation between the first three metatarsals and the three cuneiformia, and between the fourth and fifth metatarsal and the cuboid. Functional movement is some pronation and supination, part of the movement of the foot round its axis, which, however, is a function of the entire foot. We are, however, most interested in joint play. For correct examination of joint play and for mobilization of Lisfranc's articulation as a whole, we must know its anatomical course. To do this, we have to localize the proximal end of the fifth metatarsal and draw an oblique line in a medial and distal direction to the end of the first metatarsal. The course of the articulation determines the position of the hands examining joint play. Therefore, we stand at the medial side of the foot. The hand directed to the patient's head grasps the proximal part of the foot so as to fix the tarsal bones. The medial edge of the forefinger and the palm of the other hand is placed on the proximal end of the patient's metatarsals, along the oblique line described above. By minimum pressure in a dorsal direction, the slack is taken up, followed by springing, first for diagnosis. If restriction is found, mobilization takes place by rhythmic springing. The most frequent technical error is to place the mobilizing hand too close to the articulation. Chopard's articulation. Chopard's articulation can be diagnosed and mobilized in a similar way. We have to examine and restore springing between the talus and the scaphoid and between the calcaneus and the cuboid. With the patient in the same position as for treatment of Lisfranc's joint, we stand at the medial side of his foot, fixing his ankles with one hand from above. With the radial edge of the forefinger and the palm of the other hand, we contact the scaphoid and the cuboid, which is situated close to the prominence of the fifth metatarsal. By pressure in a dorsal direction, the slack is taken up, and we spring the articulation for diagnosis and mobilize it by repetitive springing. Examination and mobilization of individual tarsometatarsal and intertarsal joints. We can also be more specific, diagnosing movement restriction of individual metatarsal and tarsal bones in both a dorsal and plantar direction. The patient is supine, his leg bent at the hip and knee, supported by the heel on the table. Between our thumb and forefinger, we grasp the proximal end of a metatarsal and in the same way the corresponding tarsal bone. Fixation is provided by the hand at the tarsal bone, which must be supported. The other hand springs the joint after taking up the slack, first in a dorsal and then in a plantar direction. For mobilization, we prefer a pincer movement for better fixation. To mobilize in a dorsal direction, we place both thumbs dorsally on the tarsal bone, one reinforcing the other, and both forefingers on the plantar surface of the proximal end of the metatarsal bone. By slight pressure of our fingers, we take up the slack, followed by rhythmic springing in a dorsal direction. After this, the direction is changed by placing the forefingers on the tarsal bones and the thumbs on the metatarsals, and springing takes place by thumbs in a plantar direction. Here, too, the most frequent error is to place our fingers too close to the articulation. Restriction is most frequently found where under normal conditions there is less mobility. This is usually at the second and third tarso-metatarsal joints, less frequently at the fourth, and least at the first and fifth tarso-metatarsal joint. Mobility between individual tarsal bones can be diagnosed and mobilized in a similar way, i.e., between the cuneiform bones and the scaphoid, between the calcaneus and the cuboid, and also between the talus and the scaphoid. The cuboid can be mobilized also by fixing the ankles with one hand, while the other grasps the cuboid from the side between the thumb and forefinger, and, after taking up the slack and springing it first in a dorsal and then in a plantar direction. The navicular can be mobilized in a similar way by grasping its prominence at the medial aspect of the foot between our thumb and forefinger and springing in a dorsal-plantar direction. Our favorite technique is, however, fast shaking. The patient lies prone with his leg relaxed, bent at the knee. We grasp the foot with both hands from below, placing both thumbs, one reinforcing the other, on the plantar surface of the distal partner of two adjacent bones, most frequently on the proximal end of the metatarsal bone. Our thumbs form a fulcrum for dorsoplantar shaking with simultaneous traction. For this, we have to sense the spontaneous shaking rhythm at the site of our thumbs. Because of the distance from the heel, this rhythm is much slower at the metatarsals than at the cuboid or scaphoid. The main effect of this maneuver is probably traction. We may even deliver a thrust. It is most important for the therapist to relax so that he can feel the spontaneous rhythm of the structure he treats, as he then needs least effort. The thumbs which form the fulcrum should move only very little, and there should be next to no movement in the talocrural joint. This, like the pincer movement, is an almost universal technique which can be used for all the foot joints. As the patient has both his hands free and can reach his feet with his legs flexed, self-treatment is in his hands. It requires, however, a lot of skill, which cannot always be expected. Therefore, we usually recommend exercise on an easily obtainable special notched cylinder, as well as other sensory motor techniques. Mobilization of the calcaneus against the forefoot. First, mobilization of the calcaneus against the scaphoid and cuboid will be described. For this, the patient lies prone, the knee bent at right angles. In this way, mobilization is possible in all directions with simultaneous distraction. We stand at the side of the patient and fix his thigh close to the knee with our knee. We grasp the foot with both hands from below, one hand round the heel, the other on the forefoot. This enables us to move the patient's heel and forefoot in opposite directions under simultaneous traction. Thus, we move the heel against the forefoot in a plantar and dorsal direction, in a lateral and medial one. And even rotational mobilization can be applied, i.e. into pronation and supination. Mobilization is always carried out with simultaneous traction, and it is also important to avoid movement at the talocrural joint. Distraction is the best way to mobilize the calcaneus against the talus. Increased resistance is a sign of movement restriction. For this, the therapist stands at the end of the table and with his right hand grasps the patient's right heel, with the left hand the left heel, and leans back with his arm stretched forward to make traction easy. The other hand fixes the patient's leg above the ankle. With slight traction, he takes up the slack, followed either by springing or by a quick thrust or even fast shaking. The foot flexors and extensors can be treated by PIR and RI. If we find trigger points in the deep flexors, they can be found also in their antagonists, the extensors. The deep flexors are clinically important as they attach to the calcaneus and can be the cause of a painful calcaneal spur. Trigger points are diagnosed by deep pressure at the center of the sole of the foot. Trigger points on the dorsal aspect of the foot are diagnosed by pain on pressure between the metatarsals. PIR of the short toe flexors and the quadratus plantae. The patient is supine with his leg vertical. We grasp his heel with one and his instep with the other hand. First, the patient is taught how to make his foot small. Once he has understood, we ask him to hold this foot position against our resistance for 10 to 15 seconds, and then instruct him to let go and relax. Make your foot small. Hold it, and now relax. During relaxation, the arch of the foot flattens spontaneously. This is repeated 2 or 3 times. For reciprocal inhibition, the patient extends his toes and we flex the foot against his resistance, either by maximum force or repetitively against little force. In the course of therapy, neither plantar or dorsal flexion of the foot must occur. For self-treatment, anti-gravity technique is used. Standing, the patient flexes his foot for 20 seconds and then lets it go and relaxes for another 20 seconds. This he repeats and finally makes forceful extension of the toes for reciprocal inhibition. PIR of the extensors. With one hand we grasp the patient's forefoot and the other we place on the dorsum of the toes and flex them to take up the slack. Then we ask the patient to stretch his toes with minimum force against our resistance. Hold this position for about 10 seconds and then let go. After a short latency, relaxation occurs. This is repeated 2 or 3 times. Press slightly against my hand. Hold it. Hold it. And now relax. For our eye, the patient flexes his toes against our repeated resistance. For self-treatment, the patient is seated, supporting his heel against the opposite knee. With one hand, he flexes the foot with the toes, thus reaching the barrier. With the toes, he pushes against his hand, holds it for 10 seconds, and relaxes for another 10 to 20 seconds. During this phase, flexion increases. After 2 or 3 repetitions, he flexes his toes with constant maximum force against resistance, or repetitively with a little force. The above techniques are specific. Trigger points, however, may also disappear after fast shaking of the foot. If these techniques are not effective, we have to apply dry needling. It is not exceptional that maximum foot pronation produces pain at the medial surface, or maximum supination on the dorsolateral surface of the instep without any movement restriction or trigger points. In such cases, Jocelyne's counterstrain technique is very effective. Thus, if maximum pronation hurts, we slowly produce maximum supination. Hold it for 90 seconds, and then slowly return to neutral. Similarly, in painful supination, we move the foot into maximum pronation for 90 seconds and slowly return to neutral. After these maneuvers, pain usually vanishes. The talocrural joint. Function movement of this joint is exclusively dorsal and plantar flexion. In disturbed function, dorsal flexion is more restricted than plantar flexion. This must always be examined with the leg flexed at the hip and knee. Examination of joint play of this joint is particularly important, because here, function movement may frequently be normal, and yet joint play is clearly restricted. Joint play is examined in a dorsal plantar direction with the patient supine, his leg bent at the hip and knee. We stand at the side of the leg. With the hand pointing towards the patient's head, we grasp the distal end of the leg. The other hand, supported by the table, cradles the patient's heel, and with our forearm we splint the patient's foot so as to keep it at straight angles to the leg. By slight pressure of our forearm against the patient's leg, the slack is taken up, and springing follows for diagnosis. Mobilization is carried out by rhythmic springing perpendicular to the foot. Dorsal flexion of the foot should be avoided. A pincer movement using our fingers and thumbs is a useful alternative. The patient is supine with his leg bent at the hip and knee. We sit at the end of the table and cradle the patient's heel in the flexed fingers of both hands, both thumbs placed on the patient's shin above his ankles. With the ulnar aspect of our hand and the little finger, we splint the patient's foot so as to keep it at right angles with the leg. By slight pressure of the fingers against our thumbs, we take up the slack and can spring for diagnosis. Repetitive slower springing brings mobilization. A traction thrust, too, is both effective and without any risk. The patient is supine, his leg extended with the foot over the end of the table. If we intend to treat only the talocrural joint, we grasp the patient's instep with the fingers of both hands and place both thumbs on the sole against the metatarsals to put the foot at right angles to the leg. There should, however, never be maximum dorsal flexion to avoid locking of the joint. By very slight traction, the slack is taken up, and from this point, very fast traction follows as a thrust. There is an alternative technique by which simultaneous traction of the talocalcaneal and talocrural joint occurs. With the patient in a similar position, we grasp the right heel with the right hand, with the left hand the left heel, and with the other hand the patient's instep from the side. By very slight traction, the slack is taken up, and the thrust follows by simultaneous, very fast traction with both hands. It is essential to take up the slack with minimum force, not to back from the barrier, and to make a sudden, forceful thrust. The muscles of the calf. Most often affected is the powerful triceps surae with the most frequent trigger points in the soleus. Pain can be felt in the calf, but especially in the Achilles tendon itself and at the attachment points at the heel. It is important to decide at which side the Achilles tendon is more tender on palpation. PIR is very effective, but it is important for the soleus to lengthen. The patient is prone and the leg vertical. If the Achilles tendon is tender on the lateral aspect, we turn the foot in a medial direction. With one hand we fix the leg. The other hand moves the forefoot into dorsal flexion to take up the slack. The patient is now told, press against my hand with minimum pressure. Hold it, and let go, relax. Minimum force is essential here, as the force of the patient's triceps surae would not allow isometric resistance except against minimum pressure. During relaxation, we encourage the patient to increase dorsiflexion, even actively. Press once more very slightly against my hand. Hold it, and let go, and let the foot approach the table. As lengthening is achieved, pain at the Achilles tendon usually disappears. If the Achilles tendon is tender on the medial aspect, for therapy the foot is turned in a lateral direction. The PIR is then the same. Press with minimum force against my hand, hold this position, hold it, and now relax. Once more, push very lightly against me, hold it, and relax. For self-treatment, we use gravity-induced PIR. The patient stands in front of the table, putting one foot forward. He grasps the table with both hands and increases dorsal flexion of the front leg by bending his knee and keeping the heel on the ground to take up the slack. He now exerts isometric tension by pressing his forefoot against the ground. Holds this pressure for about 20 seconds, and then relaxes, increasing knee flexion and foot dorsiflexion, never lifting the heel from the ground. This is repeated 2 or 3 times. The fibular head. Movement restriction of the fibular head is linked to trigger points of the biceps femoris, which produce attachment point pain at the fibular head on the lateral aspect of the knee and at the ischial tuberosity on the buttock. Its great clinical importance, however, lies at the consequent dysfunction of the biceps femoris, part of the hamstrings, which are the most powerful muscles of the human body and the most important fixators of the pelvis, preventing it from dropping forward into hyperlordosis. The trigger points interfere with this function. The abdominal muscles and the glutei then have to compensate, resulting in trigger points in these muscles. Therefore, we find painful attachment points of the rectus abdominis at the symphysis, in addition to painful attachment points of the ischiocrural muscles at the ischial tuberosity. Trigger points in the straight abdominal muscles cause a forward-drawn posture. All these changes usually disappear after mobilization of the fibular head. Another consequence of trigger points in the biceps femoris is increased tension of the sacrotuberous ligament, causing fixation of the sacroiliac joint. Its mobility is frequently restored after mobilization of the fibular head. Mobilization of the fibular head is technically easy. We proceed in a similar way as in soft tissue manipulation, which can be explained because the joint is minute and most of the tissues connecting the tibia with fibula are soft. Nor are there any muscles which could move or fix the fibula to the tibia. The most effective and also the simplest technique consists in grasping the fibular head between our thumb and flexed forefinger to engage the barrier by slight pressure first in the medial dorsal and then in the lateral ventral direction. For mobilization, we wait at the barrier in the medial dorsal direction until release is obtained and follow it to the end. After this, we engage the barrier in a lateral ventral direction and wait for release to go on until the full range of movement is obtained. It is technically most important to place the mobilizing forefinger sufficiently deeply to be sure to have the fibular head between our fingers, even in obese patients. We stress that we do not move the fibula in a pure ventrodorsal direction, but rotate it round the tibia. It is important to support this movement with the other hand at the knee. If movement restriction of the fibula recurs, it is not difficult to teach the patient to do this himself in exactly the same way. Movement restriction of the fibula is so closely linked to trigger points of the biceps femoris that it is usually much easier to treat these trigger points by mobilization of the fibula than by PIR. Trigger points in the biceps femoris are diagnosed by a pincer movement between the thumb and the forefinger above the knee. For specific PIR, the patient is supine and we stand at the end of the table, at the side of the affected muscle. We grasp the right foot with the right hand, the left foot with the left, with the thumb on the patient's heel and the little finger at his little toe, so as to produce inward rotation of the foot. We now lift the patient's outstretched leg, move it into adduction, and the foot into inward rotation to take up the slack. The patient is now told, press slightly outward. We resist this movement for about 10 seconds and then instruct the patient, let go, relax. During relaxation, inward rotation, adduction, and hip flexion increase. From the position reached in this way, the maneuver is repeated 2 or 3 times. Push against my hand, hold it, and relax. For RI, the patient rhythmically activates into inward rotation against slight resistance from the therapist. For self-treatment, the patient stands with legs apart, the foot of the affected leg in internal rotation, pressed against a firm object. He now moves forward with his other leg and slightly bends this knee in order to take up the slack with the foot in inward rotation. He now exerts pressure with his foot into outward rotation and holds it for about 10 seconds, and then lets go. During relaxation, he increases inward foot rotation by increasing flexion of the other knee. Press the outward edge of your right foot against resistance. Hold it, and now relax the left knee. Bend it a little bit and relax. The knee. This is a very complex articulation. The tibio-fibular joint, which is situated at the knee, has been dealt with above. We have further to distinguish the patellofemoral joint and the tibiofemoral joint. The main function of the tibiofemoral joint is flexion-extension. But we should not forget that if the knee is flexed, there is also rotation. Finally, during flexion, a slight synkinesis into internal rotation occurs, while extension causes synkinesis into external rotation. The capsular pattern, typical for knee arthrosis, is characterized by flexion being first and most restricted, although the patient may be more aware of restricted extension, which is noticeable at every step. We, therefore, first examine maximum flexion. Because the mass of the thigh and leg muscles interfere with maximum flexion, we have to examine once in slight abduction and then adduction at the knee. The patella. In lesions of the femoropatellar joint, maximum knee flexion is usually restricted. After this, we have to examine joint play, i.e., the free shifting of the patella in all directions on the surface of the femur. In advanced arthrosis, we may find restricted mobility of the patella and increased resistance, which, under normal conditions, is minimal if the patient is relaxed. Usually, however, transitory movements are normal, as long as we do not exert pressure on the patella from above. Only when applying some pressure from above do we notice that we produce crepitation in some places if we move the patellae against the underlying femur. This is frequently painful. The transitory movements described above, combined with pressure on the patella, are used for mobilization. For this, we grasp the patella between the thumb and the forefinger of one hand, producing transitory movements, while the other hand exerts pressure from above. Where we feel some crepitation and resistance, we slightly increase our pressure as though we were trying to break up and smooth out any unevenness. This may be a little painful, but should never be severe. We believe that this is the most physiological approach for treatment of what is called retropatellar arthrosis. This condition is often found in young sports people who overstrain the joint and in whom the disturbance is still reversible. The treatment is both effective and non-invasive. In the elderly with typical arthrosis, this should also be the treatment of choice. Because the patient has no difficulty in reaching his patella, self-treatment is easy. In most patients affected by gonarthrosis, transitory movement is restricted. Just as at the elbow, we may examine in two ways. First, the patient is supine with his legs stretched out, and we stand at the end of the table. One hand is placed on the lateral surface of the thigh, the other on the medial aspect of the leg. The slack is taken up by slight pressure, followed by springing. Then the position of our hands is exchanged, one hand on the medial surface of the thigh, and the other on the lateral aspect of the leg. After engaging the barrier, springing follows. Mobilization takes place after taking up the slack, by slow rhythmic springing in the direction of increased resistance. For the other technique, we stand at the side of the patient's knee and place one hand supported by our hip on the lateral aspect of the patient's knee, while with the other we fix the patient's foot. By pressure against the knee from the side, the slack is taken up, followed by springing, producing leverage and gapping of the joint at the medial side. We then repeat the maneuver from the medial side. This technique can also be used for repetitive slower springing, for mobilization. If this procedure is not effective enough, we now use fast shaking. If restriction is diagnosed in a medial direction, we place one hand on the lateral aspect of the knee, while the other grasps the foot and rotates it medially. The hand on the lateral aspect of the knee produces fast shaking in a medial and downward direction, shaking in a fast but never forceful rhythm, corresponding to the spontaneous rhythm of the structure. If the restriction is in a lateral direction, the foot is rotated outward with the other hand on the medial aspect of the knee, and fast shaking is carried out in a lateral downward direction. Fast shaking is also most convenient for self-treatment. The patient sits on a low chair. If restriction is in a lateral direction, the leg is stretched out, supported by the outward rotated foot on the floor. With the hand of the opposite side, he grasps the knee and with slight pressure engages the barrier. Then he shakes the leg at right angles to its position in an oblique lateral downward direction. He may reinforce this hand with the other. If restriction is in a medial direction, the foot of the outstretched leg is rotated inwards, supported on its medial aspect by the floor. The hand of the same side is placed on the lateral aspect of his knee, and fast shaking is carried out at right angles to the leg, i.e., in an oblique medial downward direction. Pain originating in the hip joint can be very similar to painful conditions of pelvic and vertebrogenic origin. Pain originating at the hip often radiates to the L4 segment. The hip joint lies in the groin below the pubic bone. Its shape makes movement in all three planes possible. For diagnosis, Patrick's test is important. If mobility is restricted, the following pattern is characteristic. First, and most affected, is internal rotation. Followed by extension, flexion, and external rotation. Active abduction is usually painful as well. Pain points are found at the joint in the groin and at the attachment point of the following muscles: the adductors on the symphysis, of the gracilis and sartorius at the pes and serenus tibiae, which the patient interprets as knee pain. Also at the iliac crest and at the posterior iliac spine. The most important manual technique for treatment is post-isometric traction. It's applied most frequently in the direction of the femoral neck. By this method, relaxation of all the powerful muscles of the hip joint is achieved. For this technique, the patient is supine on the edges of the table. The clinician is sitting by the table. The patient puts his leg flexed at the knee over the therapist's shoulder, who puts his hand or forearm round the patient's thigh at the groin. We now want the patient to move his pelvis in a cranial direction, which we demonstrate passively, encouraging him to cooperate. Once he has mastered this, we tell him, "Pull my hands upwards, breathe in, hold your breath, and relax, and breathe out." The longer release lasts, the better. The maneuver must be repeated at least 3 times. Once again, pull my hands upwards. Breathe in, hold it. Relax, and breathe out. The second technique is post-isometric traction along the long axis of the leg. The patient is supine and we hold his leg above the heel, lift it 10 degrees from the horizontal, abduct it 10 degrees, and rotate it 10 degrees outward. The patient is told, pull your leg up, breathe in, hold your breath, and breathe out and relax. If relaxation is satisfactory, the leg slightly lengthens. The maneuver is repeated 2 to 3 times. Pull your leg up, breathe in, hold your breath, and breathe out and relax. There is no self-treatment in the proper sense of the word. Once, however, the patient has mastered his role, the therapist only keeps the patient's leg over his shoulder and his hands in the groin, or the patient's heel in the hand. It's thus possible for the patient's friend or partner to do this with him, if possible every day. Post-isometric traction is the most useful conservative technique of the hip joint. Fast shaking is also very effective. The patient is supine at the end of the table, legs bent at the hip and knee. We stand or sit at the end of the table and grasp his leg with both hands beneath the knee. After making sure that the patient's relaxed, we take up the slack by a slight pull in the direction of the patient's thigh and produce intermittent traction by fast shaking in the same direction.